pterygium in presence of at least one diopter of cylindrical astigmatism were included, operated by 3 consultant surgeons of at least 5 years of experience. All patients who had recurrent pterygia or any other causes of pterygium with oblique astigmatism and who didn't have 1 month of follow-up were excluded in this study. Out of 255 patients who underwent pterygium surgery during that period, 122 fit into the inclusion criteria and they were selected. The initial demographic details, best corrected visual acuity, subjective refraction, grades of the pterygium, presence of cataract and any keratometric readings using the Hewitt's autokeratometer HRK 7000 were collected during the pre-operative, post-operative 1 week and post-operative 1 month. This is the grade of pterygium which we use in this study. Just crossing the limbus is grade 1, grade 2 limbus 2 up to the pupillary margin. Encroaching upon the up to pupillary margin was grade 3 and double-headed monoocular pterygium where there was a pterygium in the same eye nasally and temporally. With the rule, astigmatism was described in the study as 90 degrees plus or minus 30 degrees and against the rule was described as 0 or 180 degrees plus or minus 30 degrees. Stability of astigmatism was considered when there was no change or change less than 0.25 diopters between 2 successive follow-up. The statistical analysis was done using the R software and p-value less than or equal to 0.05 was considered as statistically significant. Appropriate statistical tests were applied for the analysis. The mean age of presentation was 55.16 years and 90 patients, that is 73.8% had outdoor activity as an occupation, probably due to the prolonged UV light which is the causative agent for the pterygium as described by other studies which was done in South India with tropical climate. Majority of the patients presented with grade 2 pterygium, around 86 patients had grade 2 pterygium. In our study, we found that magnitude of astigmatism proportionately increased with increase in grade of pterygium, as in the double-headed monoocular pterygium here had a maximum astigmatism of around 9 diopters. We also found that 75 patients in the study had with the rule astigmatism, and then which became against the rule or neutral at post-operative 1 week, which was statistically significant. 44 of our patients had cataract with pterygium, and upon excision there was significant change in magnitude and type of astigmatism. This was the, you can just see the central 3 mm Myers is affected with pterygium with cataract. On excision, it almost stabilizes immediately. Also, there was visual acuity was 0.44 logmar at presentation preoperatively, which statistically decreased, which reduced to 0.37, which was statistically significant. In our study, we also found that the mean preoperative astigmatism was 3.31, which statistically reduced to 1.05, which was also significant. Upon subclassifying the study, we found that in grade 1 pterygium, the stability was achieved at 1 month, where there was no change, significant change between 1 week and 1 month post-op. Where in the higher grades, there was significant change in the keratometric readings 1 week and 1 month post-op. So we would just, I would just try to say the most common type of astigmatism is with the rule astigmatism associated with pterygium, and also on successful removal of pterygium, there will be improving visual acuity. I would also say the keratometry was not stabilized at higher grades at the end of 1 month post-excision, and there was a study done in Thailand by Dugatran et al. Which demonstrated minimum 3 months was required. The drawback of a study is it's a retrospective study, and we had to exactly determine the exact time taken for the stability of the keratometric data. So here we used autokeratometer, which measured 3 mm of the central cornea, which is most important in biometry or IOL power calculation post pterygium excision combined with cataract, as many of our patients had cataract with pterygium. Thank you.
My presentation.
Yeah, there were granulomas, suture granulomas, but that didn't affect the keratometric reading. And there was graft edema in this grade 3 and grade 4, which was like in the ARR. Only like 3 patients had graft edema, and suture granuloma was there in 4 to 5 patients. Yeah, that happened.
Any evidence of any graft was just extrusion of the gland? extrusion of the graft?
I have not included those cases in the only CAG, which was they were all graft necrosis or whatever displacement.
The only common problem we face is the retraction, right, on the intended side. So, do you have any problem with that? Graft retraction.
From the cell. If it is there, if it is noticed in post-op 1 week or immediate post-op, I would just do regrafting.
How did you rule out irregular astigmatism? Just saying it's caused flattening, of course, with irregular astigmatism.
I took only that is another I have taken. Only ARR, which measures only central 3 mm. That is the only instrument I have taken. And it's only the retrospective study. But I would want to do a topography just to see where the flattening exactly. Like if it is grade 1, definitely central 3 mm. As I showed that 3 mm is not affected in that. Only the peripheral myas will be affected, which will just cause an HOA, a higher order aberration, and might not actually affect the visual acuity in the center. But higher grades, as I told, grade 2, grade 3, or even this double-headed mono, they affect the central myas. The one case where I showed the central myas was affected in grade 2 with cataract. So in such cases, I would do the pterygium excision, wait for the central 3 mm at least to get a regular myas, along with the keratometric stability of 0.25 diopter, then go ahead with the cataract surgery. The standard route what we follow is like wait for 4 to 6 weeks post pterygium excision and do a cataract surgery. But when I was doing this analysis, I just found out we can't apply it for all the 0.25 diopter genes.